We're going to begin now a review of the topic of orthopedics. Now, as we did in the trauma review, this will not be a comprehensive review of orthopedics. As you know, it's a 5-year residency that is required to learn the subject matter. This will be a few hours. We will touch upon the highlights. We will emphasize those things that are most likely, in my judgment, to be on the exam. And to a great extent, we will oversimplify. We will ignore all the variations and permutations that the real practice of medicine, offers, and concentrate in the most likely way for things to be handled, to be managed, and so on. We're going to begin with orthopedic problems of children, and the first subheading has to do with the hip. So let me read the first vignette. In the newborn nursery, it is noted that a child has uneven gluteal folds. Physical exam of the hips reveals that one of them can be easily dislocated posteriorly with a jerk and a click, and return to normal position with a snapping. The family is concerned because a previous child had the same problem. Now, this is the disease entity that used to be called congenital dislocation of the hip, but is now referred to as developmental dysplasia of the hip. It is indeed a problem that occurs in families, so it is appropriate for this vignette to say that the family is concerned because the previous child had the same problem. It is also extremely important that the diagnosis be made, that the condition be recognized and the child be treated, because otherwise permanent disability may ensue. What we're talking about is a situation where the femoral heads are either outside of the hip socket, or they can easily be dislocated and may grow outside of the socket. Physical examination is often sufficient to make the diagnosis, like this vignette suggests. But if you had a question on the exam that said the family is concerned because a previous child had developmental dysplasia of the hip, they ask you, please check the baby very carefully, and the physical exam is unreliable. You cannot make up your mind. Intuitively, you would say, well, if I'm given that question on the exam, the answer will be, let's get x-rays, because x-rays is what we typically do when we don't know what's wrong with the bone. But that would not be the correct answer here, because on the day of birth there isn't a calcification yet to allow an x-ray to show the hip joint. So the correct answer, if you needed to do a diagnostic test, would be a sonogram. Okay? Now, for the management of this condition, what is done is the child is placed in a device that keeps the femoral heads inside the hip joint. Now, this can be done in a couple of ways. The standard answer would be abduction, splinting with Pavlik harness. You might hear, though, from perhaps pediatricians that have practiced in less sophisticated environments, that the same objective can be achieved by having the baby wear double diapers, and this makes the legs be abducted, the thighs be abducted, and the femoral heads then remain in place. And this is done for about 6 months to keep the femoral heads in place. Let me move on to the next one, vignette number 2. A 6-year-old boy has insidious development of limping with decreased hip motion. He complains occasionally of knee pain on that side. Let me stop here for a moment. A very important concept that we need to understand when we deal with both knee and hip pathology is that hip pathology sometimes may produce knee pain rather than hip pain. It doesn't happen the other way around. When a person has pain that originates in the knee, it is not perceived as coming from the hip. But what this means then is if we have a vignette that says the patient has knee pain we must think of the possibility of pathology in the knee or pathology in the hip. Or conversely, when we have pathology in the hip, it may hurt in the hip or it may hurt in the knee. So here we have the child saying that he occasionally has knee pain on that side. He walks into the office with an antalgic gait, that is, he's protecting that painful side. He puts less time with weight on that side than on the other. And the passive motion of the hip is guarded. Now, all of this description here adds up to a pretty good description of leg periphysis disease, which is also known as avascular necrosis of the capital femoral epiphysis. Now, the first key, the clue that we had here was the age, because this particular condition, leg periphysis disease, avascular necrosis of the capital femoral epiphysis, happens at around 6 years of age. Now, this time, you certainly could get x-rays for diagnosis, and in fact, that would be the thing to say were you to be asked what is the diagnostic test you want. And then the management after that is actually very controversial. The orthopedic community doesn't have a uniform viewpoint on how best to treat avascular necrosis in this age group. So some orthopedic surgeons would do it with casting and crutches. Others may contain the femoral head in the acetabulum in a different way. And there is even some controversy as to how this, should be treated other than that. Now, if we move to the next one, we now are moving to a little older individual. Vignette number 3 is a 13-year-old boy. Let me emphasize it for this particular entity would usually be a boy. It's a 4-to-1 ratio. And I might add, frequently a chubby, heavy, little obese 13-year-old. So a 13-year-old boy complains of pain in the groin. Remember, it could be in the knee. And is noted by the family to be limping. He sits in the office with the sole of the foot on the affected side, pointing towards the other foot. Physical examination is normal for the knee, but shows limited hip motion. As the hip is flexed, the leg goes into external rotation and cannot be rotated internally. This again is a very good description of the slipped capital femoral epiphysis, which happens to be an orthopedic emergency. And even though this child has been having the symptoms for quite some time, once this is recognized, the orthopedic surgeons immediately want to pin the femoral head in place, because the longer it stays in the abnormal position, the more likely that it is to die. The recognition is made again by x-rays. So if you're given this vignette, the next thing to do in terms of diagnosis is x-rays of the hip, and then after that, pinning of the femoral head in place in a pretty expeditious manner. Let me backtrack for a second to, again, what is the diagnostic clue here. The first one is the age, 13-year-old. And let me have one more vignette that has to do with the hip, and then we're going to review them again. Vignette number 4, a little toddler has had the flu for several days, but he was walking around fine until about 2 days ago. He now absolutely refuses to move one of his legs. He is in pain, holds the leg with the hip flexed in slight abduction and external rotation, and you cannot examine that hip. He will not let you touch it or move it. He has elevated sedimentation rate. This is again a classical description for another orthopedic emergency. This is a septic hip. The management of this one begins by putting the child under general anesthesia and aspirating the hip to confirm the diagnosis that there is pus in it. Pus, if allowed to remain within the hip, will very quickly destroy the joint, so an open arthrotomy is done for drainage, and again is done as an emergency. Let me backtrack then for a second and recapitulate the main points when it comes to hip problems in children. Our first clue, as we read the question, is going to be the age of the child. So a hip problem that is evident on the day of birth is most likely going to be developmental dysplasia of the hip. A hip problem, on the other hand, that shows up in a 6-year-old or thereabouts, we ought to be thinking of a vascular necrosis of the capital femoral epiphysis. One, on the other hand, the patient that is presented in the examination question is around age 13. It's a boy, it's a little chubby, heavy. This is going to be then the slipped capital femoral epiphysis. And finally, if it happens to be a little toddler who had a febrile illness for a few days before the problem began to show up in the hip, then we should be betting on a septic hip. Well, the same way that the little toddler that has the febrile illness and a few days later complains of hip pain, we may have a question that begins the same way but has a little different ending. Vignette number 5. A child with a febrile illness but no history of trauma has persistent, severe, localized pain in a bone. Now, this would be any bone in the body, but there's a very particular place where it hurts in that bone. When we see that question, again, same age group, a little child, a little toddler, he had a febrile illness for a few days, then he gets the pain in the bone localized. This is acute hematogenous osteomyelitis. Now, here again is an example where if you intuitively think of an X-ray, you're going to be wrong, because it takes considerable time for the X-rays to show the presence of osteomyelitis. So the correct answer for diagnosis here is a bone scan. I don't mean a CT scan of the bone, I mean a radionuclide scan, which is a very sensitive test. So the sequence here for management: bone scan first, you put the child on antibiotics. Eventually, like 2 weeks later, X-rays will show the presence of the osteomyelitis. Now, the next 2 vignettes are actually not pathological conditions. They are, in fact, things that are normal, but the family may think are not normal. And they are reasonably good points for the USMLE to test, because among other things, the USMLE wants to make sure that as a practitioner of medicine, you will not prescribe treatment or medication that isn't needed. You will not waste healthcare dollars treating what doesn't need to be treated. Let's read this. Vignette number 6, a 2-year-old child is brought in by concerned parents because he's bow-legged. He looks like a little cowboy. And vignette number 7, a 5-year-old child is brought in by concerned parents because he's knock-kneed. He's walking around knocking his knees on one another. Actually, both of these, for the age in which these vignettes are given, are normal. It's normal up to the age of 3 for kids to have genovarum, the fancy name for bow legs. And it's normal between the ages of 4 and 8 for children to have genovalgus, that is to say, knock-kneed. And so you're going to be offered, if you're given one of these questions, a number of answers, all of which would be wrong, where you prescribe orthopedic shoes or braces or crutches or, casts or whatever, none of which would be needed. Keep in mind, though, that it is the proper age group that makes it a normal situation. If you had, for instance, a child who remains bow-legged beyond the age of 3, then that in fact most likely would be Blount's disease, which is a disturbance of the medial proximal tibial growth plate. And that one might require surgery for correction. All right, let's move on to vignette number 8. A 14-year-old boy says he injured his knee while playing football. Although there is no swelling of the knee joint, he complains of persistent pain right over the tibial tubercle, which is aggravated by contraction of the quadriceps. Physical examination shows localized tenderness right over the tibial tubercle. Before I go into what this vignette is, let me backtrack and point out the importance of one line on that vignette. It'll have application to many other orthopedic questions. We're told that this child is complaining of knee pain, but there is no swelling of the knee. Now, this is a generalization I'm going to make now, Obviously, there will be many exceptions in real life, but as a rule, if there is intrinsic knee pathology, if there is something wrong with the cruciate ligaments or the menisci or the collateral ligaments, the knee will be swollen. And as a rule, again with many exceptions, but as a rule, if there is pain in the knee but there is no swelling in the knee, there is less likely to be an intrinsic problem with the knee itself. In fact, I've heard orthopedic surgeons refer to these in a good descriptive way by saying that swelling of the knee is the poor man's MRI of the knee. Now, this is a reference to the fact that the best way to see those soft tissue structures inside the knee, the cruciate ligaments, the articular cartilages and so on, the meniscus, the best way to look at those is with an MRI. And you may even be familiar with this concept just from watching professional sports on TV. When the football player is injured and they take him off the field, the announcer says they're taking him to the locker room for MRIs of the knee. But an MRI is a pretty expensive test. We're talking about over $1,000. And that's why orthopedics, faculty sometimes tell their students, swelling of the knee is a poor man's MRI. It's a quick way to say there isn't knee pathology. So going back to this vignette, the instant we read here that even though the child is complaining of knee pain, there is no knee swelling, gives you a hint that the pathology is not inside the knee. And indeed, as you read the rest, you realize that the pathology is right over the tibial tubercle. And there is an entity quite common which is responsible for this. It's got a fancy name, Osgood-Schlatter disease. Now, USMLE doesn't use eponyms, so this will be described as osteochondrosis of the tibial tubercle. They might put the Osgood-Schlatter in parentheses, but you will be given not only the eponym as the sole description, but actually the name of the disease, osteochondrosis of the tibial tubercle. This is usually treated with immobilization of the knee in an extension or cylinder cast for 4 to 6 weeks. All right, let's move on to another common orthopedic problem in children, very common in fact, vignette number 9. A baby boy is born with both feet turned inwards. If I make now my hands to be feet, they would look like this. Physical examination shows that there is plantar flexion of the ankle, inversion of the foot, adduction of the forefoot, and internal rotation of the tibia. And these 4 components are the ones that make up what is commonly known as club foot. The fancy name is talipes equinovarus. So any vignette that says that a newborn is noticed to have the feet turned inward is likely to be this. This is the most common thing. This is treated with serial plaster casts. Begin right in the neonatal period, and the sequence in which the correction is attempted begins from the most distal deformity towards the more proximal deformity. So the first thing addressed would be the adducted forefoot, then the hindfoot varus, then the equinus. About half the patients respond completely to this casting, serial casting, for about 6 months, and they need no surgery. Those who require surgery are operated on after the age of 6 to 8 months, but before the age of 1 or 2, so they are ready to walk when they are ready to walk. Vignette number 10 is a brief look at a field that in fact in real life is a highly specialized, very complex field, that of scoliosis. Vignette number 10, a 12-year-old girl is referred by the school nurse because of potential scoliosis. The thoracic spine is curved toward the right, and when the girl bends forward, a hump is noted over her right thorax. The patient has not yet started to menstruate. Well, as I indicated a second ago, this is indeed a very complicated field. Orthopedic surgeons who treat this problem are usually people who specialize in problems of the spine. And so what we're about to go into now is obviously a very brief oversimplification of a problem. But let me go through the highlights of scoliosis. It's a problem that affects primarily girls, almost exclusively girls, and it happens during those years when the spurt of growth takes place. The earliest manifestation, the quickest way to tell that a young lady is developing this problem is, in fact, as described here, to look at her from behind, and rather than trying to see the S form of a thoracic spine, which may not yet be evident, is to have her bend over forward and looking at her from behind. If she has scoliosis, the right hemithorax will be higher than the left. There is that hump over the right hemithorax. Later on, when there is more progression of the disease, the S deformity will be obvious. And the key thing about the disease is, in fact, progression. And the reason scoliosis is so important is because it begins as a relatively mild problem, but as long as a young lady has not reached skeletal maturity, it may continue to progress, and it may progress to the point of very, very severe deformity. So orthopedic surgeons, as soon as they detect the presence of scoliosis in a young lady, will use a number of devices, corsets and casts and things to keep that spine from deforming anymore, and if necessary, surgical interventions, up until the time when the girl has reached skeletal maturity, because beyond that point there is no further progression of the disease. It is for that reason that the vignette points out that the little lady has not yet begun to menstruate. Menstruation is a good point in which to make a guess as to how far along we are on skeletal maturity. It's roughly 80% along when a young lady begins to menstruate. So if we're told in the vignette that the young lady has not yet begun to menstruate, that means that disease will continue to progress because she has not yet reached skeletal maturity. Again, I don't think they'll ask you for many more details on the management. It's a highly complex issue, but there will be, as I pointed out, the need to use braces or casts or some other way to correct the problem. If it isn't corrected, let me add, the issue is not only one of deformity, which is indeed very bad, but pulmonary function could be limited if there is a large deformity, and actually there may be even cor pulmonale resulting from it. All right, we're going to move on now to fractures, but we're still talking about children. Okay, so let's talk about fractures as they pertain to children, and let me begin with a little general statement. In most respects, fractures in children are easier to handle, have a better outcome than fractures in adults. It begins with the fact that children are less likely to break their bones in the first place. They are more plastic, they bounce rather than break. If they have fractures, they are more likely to have the green stick type rather than the clean break. And if they do get a fracture, they have two excellent patterns of the healing of a fracture. One is they heal much faster than the adult does, but the real remarkable one is they have a tremendous capacity for remodeling. So a broken bone that might be set and immobilized in an unacceptable position, in the adult it would lead to a deformity, in the child it typically does not, because the remodeling is so outstanding that a few months later that bone is completely straight and looks completely normal, even if it looked relatively bad at the time that it was dealt with. So all of these are the good things about fractures in children. The bad things, though, too. There is one specific type of fracture, we're going to deal with it in a second. It affects the elbow, where the child is at very high risk of neurovascular compromise, more so than the adult. But the other important issue is when the fractures involve the growth plate. So when we have the growth plate damaged in the course of sustaining a fracture, that could lead to problems with the further growth of that bone. Let's go through the 2 or 3 vignettes that we have. Vignette number 11, a 4-year-old falls down the stairs and fractures his humerus. He's placed on a cast at the nearby dock in the box. Let me say, by the way, USMLE will not use that kind of language. Doc in the box is a colloquial expression in the U.S. that denotes a small clinic that handles minor emergencies and is perhaps not equipped to do real forensic work. So the kid is placed on a cast at this facility, and then he is seen by his regular pediatrician 2 days later. At that time, he seems to be doing fine, but AP and lateral X-rays show significant angulation of a broken bone. You're then going to be asked, should we remove the cast, break that bone, put it together again? Should we do open reduction, internal fixation, etc.? None of which are needed. We can simply count on the amazing ability of children to remodel. It can be left the way it is. When you do X-rays on the same child 2 or 3 months later, it'll be hard to believe it's the same person. The bone will be completely straight. All right, vignette number 12. An 8-year-old boy falls on his right hand with the arm extended, and he breaks his elbow by hyperextension. X-rays show a supracondylar fracture of the humerus. The distal fragment is displaced posteriorly. A supracondylar fracture of the humerus in an adult is just like another potential fracture of the humerus. But in children, that particular location has a very high incidence of neurovascular compromise. So that if you find this question, it's a child fell with the extended arm, and you read those words, supracondylar fracture of the humerus, the answer you're looking for in that question is the one where you pay tremendous attention to the vascular supply of that extremity. It will either be monitoring the pulses, monitoring capillary feeling, perhaps in a more technological way, Doppler studies, but you get the idea. What they are asking you to do in this child is to monitor very carefully the vascular supply, because this particular fracture in this particular age group has that high incidence of that complication. Incident of the fracture itself can be treated in a simple manner. It doesn't necessarily require open reduction and internal fixation. It can be put together, it can be casted. All right, now we're moving on to those fractures in children where the growth plate is involved. Vignette number 13, a child sustains a fracture of a long bone involving the epiphysis and growth plate. The epiphysis and growth plate are laterally displaced from the metaphysis, but they are in one piece. That is to say, the fracture does not cross the epiphysis or growth plate and does not involve the joint. And contrasted with that, on vignette 14, a child sustains a fracture of a long bone that extends through the joint, the epiphysis, the growth plate, and a piece of the metaphysis. Namely, the growth plate is now in 2 pieces instead of 1. Now, this is a summary what these 2 vignettes represent of a slightly more complex thing in real life. There is a Salter classification of fractures that involve the growth plate and has like 5 or 6 different types. But the key that I focused in here is if the growth plate is in 1 piece, as in the first of these 2, it can be pushed back into place, a cast can be applied, and the outcome will be fine. But if the growth plate is broken in 2 pieces, then very precise alignment is needed, because otherwise the growth could be uneven in the future. So as a rule, again, with probably a million exceptions, but as a rule, if the growth plate is in 2 pieces, 2 separate pieces, then an open reduction and internal fixation is better in order to put them where they belong. All right, we're still talking about young people, and now we're going to move on to tumors. Because as it happens, primary malignant tumors of the bone are a problem that affect primarily children and young adults. And I often point out to my students that I may die of any number of horrible diseases myself, but I tell them it will not be a primary malignant tumor of the bone, because I'm too old for that. Of course, I could get a primary malignant tumor of the bone marrow, but that's another story. That would be a multiple myeloma. So the primary malignant tumors of the bone belong to young people. I might add, like we said for scoliosis, they also represent a highly specialized field. Orthopedic surgeons that have already the full 5 years of training in the field may take additional training to then devote their careers to the treatment of primary malignant bone tumors. So obviously what follows now, it's a very, very oversimplification of such a complex field. But I think one of the things that I would like you to know for the exam is how to recognize a malignant bone tumor versus a benign bone tumor. Let me read vignette 15, and then I'm going to go back for the details. Vignette number 15. A 16-year-old boy complains of low-grade but constant pain in the distal femur, present for several months. He has local tenderness in the area, but is otherwise asymptomatic. X-rays show a large bone tumor with sunburns pattern and periosteal onion skinning. Now, the history of a primary malignant bone tumor will always begin this way. So when you see that question, is going to be a young person, 5, 8, 10, 12, 15, 20, 25 years old, and the presentation will be just as I read. This individual has been complaining of constant pain in a bone, in a specific place in a bone. Eventually, as help is sought for it, an X-ray is taken. And when the X-ray is taken, lo and behold, here is the bone tumor. Now again, in an oversimplified manner, let me emphasize for you, and I'm going to go to the board and make a couple of drawings for this. What are these characteristics, radiological characteristics, of a malignant as opposed to a benign bone tumor? If we have a benign bone tumor, this is an end of a bone, if we have a benign bone tumor growing there, typically that benign tumor has a sharply demarcated edge that distinguishes it from the rest of the bone. And so in this drawing here, we can see clearly that there is a boundary here between the benign tumor and the rest of the bone. The primary malignant bone tumor, on the other hand, has a very fussy, ill-defined edge between tumor and bone. It would look, again, in a cartoon-like depiction like this. And this is what the radiologists call the sunburns pattern. It looks like again, like the drawing of the sun. So this is one of the characteristics that allows you to recognize this question is dealing with a primary malignant bone tumor. The second one, which I have read already, is what's called the periosteal onion skinning. Here is the idea. This tumor is growing so fast that as it grows, it pushes up the periosteum away from the rest of the bone. The periosteum, when that happens, then lays a new layer of bone, but soon after doing that gets displaced again. And so layers of bone are laid one after the other, and this would resemble the layers of an onion, and that's why this is called the onion skinning. So without getting into more complicated details, if you have a question on the exam that says a young person is having pain in a bone for 2 or 3 months, the X-ray has been taken, and the radiologist says there is a sunburns pattern and there is periosteal onion skinning, then we know that we're dealing with a malignant bone tumor. Let me add a little additional detail. There are two main, well, I shouldn't say two main, they are the two most common primary malignant bone tumors. Are osteogenic sarcoma, that's number one, and Ewing sarcoma, which is number two. Osteogenic sarcoma tends to happen in slightly older kids, ages 10 to 25, and it usually occurs around the knee, that is to say, either the lower end of the femur or the upper end of the tibia. Whereas the second most common, the Ewing sarcoma, affects kids that are a little younger, 5 to 15 and typically grows in the diaphysis of a long bone, right in the middle of the bone instead of the ends of the bone. And so if we go back now to the vignette we read, 16-year-old boy, he has a primary malignant bone tumor, which you already recognize, but it is in the distal femur. Well, there would be a good possibility this might be an osteogenic sarcoma because of the location, because of the age. As I read the next one, though, you might see the characteristics of the Ewing sarcoma, vignette number 16. A 10-year-old complains of persistent pain deep in the middle of the thigh. X-rays show a large bone tumor in the diaphysis of the femur with sunburns pattern, periosteal skinning. This one might be more likely to be a Ewing sarcoma. Again, because it's a little younger, because it's in the middle of the bone. Let me reassure you that probably you will not be asked on the USMLE to specify the particular kind of tumor. This is, again, highly specialized. But I think you will be expected to know radiological signs of primary malignant bone tumor versus benign tumors. If they ask you further, what are you going to do for this child now that you know he's got a primary malignant bone tumor? Well, you're not going to do anything. You're going to refer that child to that highly specialized orthopedic surgeon who has had additional training in primary malignant bone tumors. So don't pick the answer where you put needles into that bone or try to take a piece or do a biopsy. You're not going to do anything invasive to that thing. All right. Let's move now to adults. We're done with the children. Let's move now to orthopedic problems in the adult. But we were talking about bone tumors in the children, so let's begin the adults with tumors that affect the bone. But in the adult, they're going to be mostly metastatic tumor to the bone rather than primary bone tumor. Let's begin. Vignette number 17. A 66-year-old woman picks up a bag of groceries and her arm snaps broken. This is what we call a pathological fracture, that is to say, a fracture that happens for trivial reasons. Now, often when I'm asked questions about these in reviews with a live audience, and I point out that when you have trivial trauma and bone breaks, this is a pathological fracture that signifies the presence of a metastatic tumor. I'm always asked, well, what about osteoporosis? 66-year-old woman, she's bound to have osteoporosis. Yes, osteoporosis makes it easier for you to break your bones, but except for vertebral bodies where you could have that compression fracture for no particular reason, in other bones in the body, you need a little more trauma. The osteoporotic lady, to break her arm, she needs to fall. So when you have this story, like I just read, pick up a bag of groceries, the arm snaps in two, that will always mean there is metastatic malignant tumor to that bone that broke. So the first thing we're going to do, obviously, is take an X-ray, and the X-ray will probably show a lytic lesion. That is one of those metastatic lesions that has eaten away the bone, as opposed to a blastic lesion where there is growth of bone. And in fact, in this vignette that I just read, being a lady, we have to assume the breast to be the most likely primary source. Had it been a man, the most likely primary source would have been the lung, not the prostate, even though the prostate is sort of the equivalent in the male to the breast cancer in the female, because the bony metastases from prostatic cancer are osteoblastic rather than osteolytic. Okay? But the vignette might give you additional clues. The vignette may say, an old person sustains this pathological fracture, and may say, and this person has been coughing and spitting out blood, so you then have reason to believe it's coming from the lung, or this person has had hematuria, you're thinking of the kidney or whatever. All right, vignette number 18 represents the only primary malignant tumor affecting the bone that we see in old people, although, as we shall see in a second, it doesn't grow from the bone but from the bone marrow. 60-year-old man complains of fatigue and pain at specific places on several bones. Is found to be anemic, and X-rays show multiple punched out lytic lesions throughout the skeleton. This is a classical presentation for multiple myeloma. An old person, anemic, and multiple bones involved. Now this is also the disease entity you might remember from medical school that has all those funny things in the blood and the urine. This is the one that has the Banks-Jones protein in the urine and the abnormal immunoglobulins in the blood. So proper workup of these would begin with that. Look for the Banks-Jones proteins in the urine, do immunoelectrophoresis to look for the abnormal electrophoretic pattern in the blood, and chemotherapy is the usual treatment. And moving then away from the bone, but is still on the topic of malignant orthopedic tumors in the adult, vignette number 19. A 59-year-old or 58-year-old woman, makes no difference really, has a soft tissue tumor in her thigh. It has been growing steadily for 6 months. It's located deep into the thigh. It's firm, fixed to surrounding structures, measures about 8 cm in diameter. This should be a soft tissue sarcoma. So someone in this age group with a soft tissue mass that grows and grows and grows, and after a number of months already has a sizable, diameter like that, and it seems to be hard and it seems to fix to surrounding structures. This is a sarcoma. Now we have no idea at this point whether this is a liposarcoma, a fibrosarcoma, a chondrosarcoma, a rhabdomyosarcoma. We have no idea. All we can tell is this is a soft tissue sarcoma. The first thing you would probably do on this one would be an MRI. The MRI is a very good way to look at soft tissue tumors. In fact, we're kind of developing a pattern here from previous vignettes when we talked about trauma, from the vignettes we're already beginning to cover. When we're looking for soft tissue pathology, often the MRI is a good way to do it, and the soft tissue sarcoma is another example of that. But beyond doing the MRI, be sure that you do not pick any answer on the exam where you might do invasive things to that soft tissue tumor. To diagnose sarcoma, the pathologist is going to need a big piece of tissue. A sarcoma cannot be diagnosed on a fine needle aspirate, and so an open biopsy is going to be required. If an amateur does the open biopsy, puts a cut over the tumor to take a piece, then in the subsequent treatment that will eventually have to be done by the expert, that incision that was made is going to compromise now the next step in treatment. Now the incision to be made for the removal of the tumor will by necessity have to include and resect the track of the previous incision. This may force the incision for treatment to be placed in a less than ideal location. Bottom line, do not pick an answer where the person who discovered this tumor does the biopsy, puts needles in it, okay? MRI, referral to the expert, that's all. All right, now we move on to general orthopedics, and we're going to talk about common adult orthopedic injuries. Again, I realize I'm repeating myself, but I have to emphasize again, these are highlights. This is just the most common form, the most usual treatment. All of these little vignettes that follow will, in real life, have all kinds of variations and permutations that we don't have the time to cover and probably will not be in the exam. Vignette number 20. A man who fell from a second floor window has clinical evidence of fracture of his femur. The vignette gives you a choice of x-rays to order. So here are the rules. If you think that a bone is broken and you want to verify these with x-rays, you need x-rays at 90 degrees to one another. Typically that would be AP and lateral, okay? And the x-rays must include the joint above and the joint below the bone that you're looking at. But there is a little bit more. In this particular vignette, we were not simply told, we think the femur is broken, what x-ray should we get? We were told, how did it happen? And many times the mechanism of injury suggests the possibility of additional injuries that may not be immediately obvious. And in this case, if somebody fell from a height and broke a leg, the way the trauma happened could also have resulted in compression fractures of vertebral bodies. So a better answer on this one would be not only AP and lateral of the femur with the two joints included, but also x-rays of the lumbar spine that may have suffered in the same event. Vignette number 21. While playing football, a college student fractures his clavicle. The point of tenderness is at the junction of the middle and distal thirds of the clavicle. This is a classic, extremely common injury. That's where it happens, junction between the middle and distal thirds of the clavicle. And this is treated simply with a figure-of-8 device for 4 to 6 weeks. A figure-of-8 device is that kind of a arrangement that keeps the shoulders back. It's a bandage that is applied to keep the shoulders back like that, and therefore the bone in the proper alignment. Vignette number 22, a 55-year-old woman falls in the shower and hurts her right shoulder. She shows up in the ER with her arm held close to her body, but rotated outwards as if she were going to shake hands. Please look at me, because this is a classical presentation. You may have this picture on the exam. You may see the patient like this, rather than the way you would expect somebody who injured the shoulder to be. The more typical protective position for an injured shoulder is to be like this. So when the patient is like this, you already are beginning to have a clue to the diagnosis. The diagnosis being an anterior dislocation of the shoulder. Let me keep reading. So she shows up in the ER with her arm held close to her body but rotated outwards as if she were going to shake hands. She is in pain and will not move the arm from that position. And there is numbness in a small area of her shoulder over the deltoid muscle. If you needed an extra detail, you have it right there. That's axillary nerve damage, stretching of the axillary nerve. Let me point out that of the two kinds of dislocation of the shoulder, by far the most common is this one, the anterior dislocation. It can happen with regular, standard kind of trauma, like this lady falling in the shower. Again, you can recognize it from the position of the patient and perhaps the additional information about the stretching of the axillary nerve. X-rays, AP, lateral, will make the diagnosis, and then reduction follows. Now, the other kind of dislocation of the shoulder, the one that is less common, is a posterior one, but it's very easy to recognize on the exam. Let me read the vignette and then we'll analyze what made it so easy to recognize. This is now vignette 23. After a grand mal seizure, a 32-year-old epileptic notices pain in her right shoulder and she cannot move it. She goes to the nearby doc in the docks. Again, the vernacular for she goes to a small clinic that is not equipped to handle very complicated cases, where she has x-rays and is diagnosed as having a sprain and given pain medication. The next day she still has the same pain and inability to move the arm. She comes to the ER with the arm held close to her body in a normal protective position. That is to say, not externally rotated like the previous one, but internally rotated. All right, this is a posterior dislocation of the shoulder. What allowed us to recognize this right away? Well, whereas the anterior dislocation happens with a standard kind of trauma, the posterior dislocation typically happens when all the muscles in the body contract at the same time. You might recall that we visited this briefly earlier when we talked about electrical burns. And we pointed out that in electrical burns, one of the potential additional injuries is posterior dislocation of the shoulder. Well, here we have another classical example. Epileptic seizures, uncoordinated contractions of a lot of muscles, and that can drive the humeral head out towards the back. The second thing that made it easy to recognize is that these are very difficult to diagnose with regular x-rays. And so the fact that she had a set of x-rays and the diagnosis was not made is in fact something that again allows you to guess this is a posterior dislocation. So what do? Well, we get x-rays, but this time we get the proper ones. And what you need here are axillary views or scapular lateral view. So if you have this question on the exam, look for the answer that says repeat x-rays of the shoulder including axillary view or including scapular lateral views. And then of course the reduction will follow. All right, vignette number 24. An elderly woman with osteoporosis falls on her outstretched hand. She comes in with a deformed and painful wrist that looks like a dinner fork. X-rays show a dorsally displaced, dorsally angulated fracture of the distal radius. The vignette may also say a small fracture on the ulnar stylus. Remember that when you have two bones together, like we do in the forearm, if one of them breaks, then typically the other one either also breaks or dislocates. Now the main fracture here, though, is the one that is affecting the radius, and this is the classical Colles fracture, a very common thing. The Colles fracture is treated with close reduction and a long arm cast. You were able to recognize it because of a dinner fork deformity. That's the clue. And incidentally, here's a good example of how the elderly osteoporotic may easily break a bone. She still has to fall to break the bone. All right, vignette number 25. During a rowdy demonstration and police crackdown, a young man is hit with an ice stick on his outer forearm that he had raised to protect himself. So he went like this and he was hit. He is found to have a diaphyseal fracture of the proximal ulna with anterior dislocation of the radial head. This is a very common, again, another classic fracture of the upper extremity. It happens to be called Montegia fracture. You will not be expected to know the eponyms on the exam. And so the broken bone in this case is the ulna, the dislocated bone is a radius. In the majority of cases, there will be obviously variations of permutation, but in most cases, close reduction of the radial head is possible, and open reduction and internal fixation of the ulnar is more commonly required. So the rule here, again with exceptions, is open reduction, internal fixation for the broken bone, and close reduction for the dislocated one. Well, this particular fracture has an almost mirror image counterpart. Let's read vignette number 26. Another victim of the same melee has a fracture of the distal third of the radius and dorsal dislocation of the distal radio-ulnar joint. So if the blow, instead of coming directly at the ulna, in fact came at the radius, then it is the radius that breaks, and then it is the ulna that is dislocated. And as in the previous one, there is a proper name. This one happens to be Galeazzi fracture. You won't need to know that. And as in the previous one, in general, with exceptions, but in general, the open reduction, internal fixation is the most commonly used thing for the bone that's broken, and the reduction, manual reduction of the one that's dislocated can be done, and then the casting of the forearm is done in supination to maintain that reduced dislocated joint. All right, we move on now to vignette number 27. A young adult falls on an outstretched hand and comes in complaining of wrist pain. On physical exam, he's distinctly tender to palpation over the anatomic snuff box. AP and lateral x-rays are read as negative. This question has a very, very high likelihood of being on the exam. An exam question that obviously shows a broken bone doesn't really present much of a diagnostic challenge. The only thing is, how do we put it together? And the fourth-year medical student for whom this exam was designed isn't really expected to know how to put together the bones. That's the job of the orthopedic surgeon. But the USMLE emphasizes things that every practitioner of medicine should be able to recognize. And this is a classic, because in fact this individual, even though he had negative x-rays, has a fracture. It happens to be a fracture of a carpal navicular bone, the scaphoid bone. Why do we know that? The individual fell on an outstretched hand. He comes in complaining of wrist pain, and he has that very precise location of pain at the anatomical snuff box. And that's enough to diagnose the fracture of the carpal navicular bone. And these fractures are notorious for not showing up on the first set of x-rays. And so if we put blind faith on x-rays as being omnipotent and always telling the truth, you're going to be misled. You'll be misled in real life, allowing this patient to go on without proper immobilization, or you'll be misled on the exam and pick the wrong answers. So you should realize when you're given this presentation that even though the x-rays were read as negative, that's in fact one of the things that identifies for you that this is a fracture of the carpal navicular bone, scaphoid bone. So the patient needs to be put on a thumb spike cast, and then 3 weeks later, if you take x-rays again, then you will see it. Now this very same fracture, carpal navicular bone, is also notorious for another trait, for another thing that it can do, which is exemplified in the next vignette. Vignette number 28. A young adult falls on an outstretched hand, comes in complaining of wrist pain. On physical exam, he's distinctly tender to palpation over the anatomic snuff box. AP, lateral, and oblique x-rays show a displaced and angulated fracture of the scaphoid. Now, in this case, there was no radiological problem diagnosing the fracture, but if it is that displaced and out of place that the x-rays easily recognize the presence of a fracture, then that other trait comes to the fore. These are notorious for very high rate of non-union, non-healing, delayed healing. And so when it is displaced and angulated, an open reduction and internal fixation is preferred. Let me repeat this too, because again, they have a very high likelihood of being on the exam. The mechanism of injury, which is your first thing you recognize when you begin to read the vignette. A young adult falls on an outstretched hand. You're already thinking this is going to be carpal navicular bone. And then comes the next thing, the distinct pain to palpation in the anatomical snuff box. You know it. If a vignette that goes on to say x-rays were read as negative, you know the fracture is there, but obviously not displaced, you need the cast. But if a vignette goes on to say x-rays show displaced, angulated fragments of the bone, then open reduction and internal fixation. All right, vignette number 29. During a barroom fight, a young man throws a punch at somebody but misses and ends up hitting the wall. He comes in with a swollen and tender right hand. X-rays show fractures of the 4th and 5th metacarpal heads. Next. This is very common. The 4th and the 5th metacarpal necks are the place where we break our hand if we hit the wall with a closed fist. How we manage this depends on the degree of angulation, displacement, or rotary malalignment. Close reduction and an ulnar gutter splint can be used for the mild ones, and Kirschner wire plate fixation for the bad ones. All right, let's move now to the lower extremity. And we begin the lower extremity again with a set of vignettes that are very common problems in real life. They cost the U.S. healthcare system millions and millions of dollars every year. They are even the cause of significant morbidity and mortality. They are very likely to be on the exam. Opinion number 30. A 77-year-old man falls in the nursing home and hurts his hip. He shows up with the affected leg shortened and externally rotated. X-rays show that he has a displaced femoral neck fracture. Let me read this again, highlighting the important points. The hip fracture that we have mentioned as a very severe public health problem affects the elderly. So the vignette is going to be an old person in a nursing home who slipped and fell and hurt his hip. When you are told the deformity, or perhaps shown the deformity on a picture on the exam, you should be able again to recognize it instantly. That affected leg is shortened and externally rotated. So shortened and externally rotated, you already know this is going to be a broken hip. But where exactly is the fracture will be evident in the X-rays, and it's important because different locations call for different treatment. The femoral neck, as you know, is a place that has very tenuous blood supply going to the femoral head. And so if we read, as I just did, that the X-rays show a displaced femoral neck fracture, the likelihood that the femoral head will survive is very small. If this patient is operated on and pinned together or put on a cast or on traction hoping for healing, the healing probably will not take place. The femoral head is going to die. All that time this old individual is immobilized, he's going to get pneumonia, he's going to die. And so when we have a displaced femoral neck fracture, the standard approach is to take that patient to the operating room and remove that femoral head and put a metal prosthesis. So a metal prosthesis would be the appropriate management for the displaced femoral neck fracture in the old patient. In contrast to that, if we read the next one, vignette number 31, a 77-year-old man falls in the nursing home and hurts his hip. He shows up with the affected leg shortened and externally rotated. You already know this is going to be a broken hip. It's an old man, fell in the nursing home, the leg is shortened, externally rotated. But if it goes on to say X-rays show that he has an intertrochanteric fracture, not femoral neck, but further down in the bone, intertrochanteric. These can heal. So the standard approach for this is open reduction and pinning. So these are put together in place. Immobilization, however, will have to follow. And these old people are very prone to develop deep venous thrombosis and, of course, pulmonary emboli from that. So that an additional component of the correct answer has to be post-operative anticoagulation. Okay? So we have to pick on this one the answer that says open reduction, pinning, and post-operative anticoagulation. All right. Opinion number 32, we're now moving down in the extremity. The unrestrained front seat passenger in a car that crashes sustains a closed fracture of the femoral shaft. As a rule, intramedullary rod fixation is a standard treatment for those. Now, the femoral fracture, we have to remember, can give us problems other than just that broken bone. And this is a good point in our review to remind ourselves of what they could be. Let's read. Vignette number 33. The unrestrained front seat passenger in a car that crashes sustains close comminuted fractures of both femoral shafts. Shortly after admission, he develops a blood pressure of 80/50, a pulse rate of 110, and a venous pressure of 0. And we should be now recognizing from our previous review of trauma that here is a trauma victim going into shock with a venous pressure of 0, and that means he's bleeding somewhere. That means this is hypovolemic hemorrhagic shock. The question then is, where is he bleeding? The rest of his physical examination and X-ray survey, including chest and pelvis, are unremarkable. And sonogram done in the abdomen and the ER was likewise negative. Well, we rule out intra-abdominal bleeding, we rule out the pelvic fracture, we rule out bleeding into pleural space, and we know, and we should remember again from our previous review of trauma, that comminuted fractures of the femurs, particularly if it's on both sides, that there is enough blood that can be lost in the area to account for hypovolemic shock. So this is why this patient is in shock. This patient obviously needs blood, but remember, one of the essential features in the treatment of hemorrhagic shock is stop the bleeding also. And at the very least, if there are other injuries that may delay further management of this individual, at the very least, some kind of fixation will diminish the blood loss here. So that, look for the answer here where you do, it could be external fixation. If there is no time to do more detailed work on that bone, it could be internal fixation, the definitive treatment for it. All right. Move on to another, again, feature of the long bone fractures, of which a femur is an example. Vignette number 34. The unrestrained front seat passenger in a car that crashes sustains close comminuted fractures of both femoral shafts. 12 hours after admission, he develops disorientation, fever, scleral petechia. Dyspnea is evident shortly thereafter, at which time blood gases show a PO2 of 60. And we should recognize again, because we reviewed it already in the trauma vignettes, that this is fat embolism. The bones broken would not necessarily have to be the femur. It could in fact be the tibia and fibula, it could be long bones in the arms. But you have fractures of long bones followed within a few hours by respiratory distress and a low PO2. That is a fat embolism syndrome. And if you remember, the centerpiece of the management there is a respiratory support. This patient will need to be placed on a respirator to improve his oxygenation. All right, we now keep moving down the lower extremity to the knee. Vignette number 35. A college student is tackled while playing football and develops severe knee pain. When examined shortly thereafter, the knee is swollen. The knee is swollen. Let me repeat, there is probably pathology in the knee. Remember, the swelling of the knee is the poor man's MRI of the knee. And he has pain on direct palpation over the medial aspect of the knee. With the knee flexed at 30 degrees, passive abduction elicits pain on the same area, and the leg can be abducted further out than the normal contralateral leg. And this is called a valgus stress test. When you read this identifies, of course, an injury to the medial collateral ligament. It is there where the pain is felt on palpation. And then when we bend the leg, we can bend it further in the direction in which that broken ligament no longer limits the motion. So it is therefore the valgus stress test, the abduction of the leg, that can go beyond the normal boundaries. And the next vignette will be the mirror image. A college student is tackled while playing football, develops severe knee pain. When examined shortly thereafter, the knee is swollen. He has pain on direct palpation, now in this case, over the lateral aspect of the knee. And with the knee flexed at 30 degrees, passive adduction elicits pain on the same area, and the leg can be adducted further out than the normal contralateral leg, which is a varus stress test. In either of these cases, in fact, the mechanism of injury is obvious. If you're standing like this and you get hit from the lateral side and you bend that knee, it's the medial ligament that breaks. If you, on the other hand, are hit from the medial side, it is a lateral ligament that breaks, because it breaks not where the trauma came, but where the bending took place. Now, for either of these injuries, a hinge cast is the usual treatment if that's the only injury the patient has. If several ligaments are torn, then surgical repair might be preferred. All right, move on to vignette number 37. A college student is tackled while playing football, develops severe knee swelling and pain. From physical exam, with the knee flexed at 90 degrees, the leg can be pulled anteriorly like a drawer being opened. A similar finding can be elicited with the knee fixed at 20 degrees by grasping the thigh with one hand and pulling the leg with the other. Both of these things identify a lesion of the anterior cruciate ligament. And it's easy to remember, because if it's the anterior cruciate ligament that is injured, it's the anterior drawer test. We can pull that leg like a drawer being opened. If it had been the posterior cruciate ligament, it would have been the opposite. We would have been able to push that leg in like you're closing a drawer. So the diagnosis here obviously then is a lesion of the anterior cruciate ligament. The next test, if you're asked for how can we see that ligament and verify what has happened to it, would be the MRI, as we pointed out before. Sedentary patients may be treated with immobilization and rehabilitation. Athletes usually end up for arthroscopic reconstruction because they need to heal faster, they need to be able to go back to play again. All right, vignette number 38. A college athlete injured his knee while playing basketball. He has been to several physicians that have prescribed pain medication, a variety of splints and bandages, but he still has a swollen knee and knee pain. He describes catching and locking that limit his knee motion. And he swears that when his knee is forcefully extended, there is a click in the joint. And he's been told that his x-rays are normal, and this is a pretty classical description for an injury of the meniscus. Meniscal tears may be difficult to diagnose clinically, and of course also difficult to diagnose on plain x-rays because the meniscus is not visible on x-rays. MRI, however, will show them beautifully. So if you're asked what to do next on this patient, it will be an MRI of the knee. Arthroscopic repair is done for these, but I should emphasize, because it may be part of the question, that we try to save as much of the meniscus as possible. If an extended meniscectomy is done, then degenerative arthritis is very likely to ensue. And if a complete meniscectomy is done, degenerative arthritis will ensue. Let me go back again to what allowed you to recognize this. A couple of things. The main one is that limitation, that locking of the knee joint. And then the fact that it was difficult to diagnose. So a long-standing problem, the knee keeps locking, you cannot move it to full extent, that's going to be a meniscal injury. Well, let's move on to another one which has a good chance of being on the exam because it calls for that clinical acumen that goes beyond reading x-ray reports. Vignette number 39. A young recruit complains of localized pain in his tibia after a forced march at boot camp. He's tender to palpation of a very specific point on the bone, but x-rays are normal. And so if you didn't know any better, you would say x-rays are normal, the bone could not possibly be broken or have anything wrong. In fact, this is a stress fracture. And stress fractures are notorious because they do not show up on day one. You're going to have to wait a couple of weeks for that x-ray to show the fracture. Just on the basis of a clinical presentation, you can treat the patient as if he had a fracture, namely, you put him on a cast. You know, you could have this one presented to you in a slightly different way because the key to this one is the repetitive use of that bone, way beyond where the bone could tolerate it. The forced march at boot camp is a good example, but another good example would be the patient intent on completing and running the marathon. He may not be in good shape to do it. He's been running and running for hours and it's already hurting on his leg, but that drive and that desire, I have to finish the marathon, he does it to the point of producing the stress fracture. All right, vignette number 40. A pedestrian is hit by a car. Physical examination shows the leg to be angulated midpoint between the knee and the ankle. X-rays confirmed fractures of the shaft of the tibia and fibula. This is a classic also. This is the height of a bumper of a car. So when you get hit by a car, it's frequently the lower leg that gets the brunt of the trauma. And as we pointed out earlier, when we have two bones together in a segment of our anatomy, one breaks, the other one typically breaks too or dislocates. So here we have the fracture of both the tibia and the fibula. Casting can be done for the ones that can easily be reduced. Intramedullary nailing is needed for the ones that cannot be aligned. But let's not leave this topic yet, because there is another angle, another version, another feature of these fractures that may very well be on the exam. Let's look at number 41. The pedestrian is hit by a car. Physical examination shows the leg to be angulated midpoint between the knee and the ankle. X-rays confirm fractures of the shaft of the tibia and fibula. Satisfactory alignment is achieved and a long leg cast applied. In the ensuing 8 hours, the patient complains of increasing pain. When the cast is removed, the pain persists. The muscle compartments feel tight, and there is excruciating pain with passive extension of the toes. This is a classic. This is a compartment syndrome. In fact, I'm going to repeat compartment syndrome a good number of times before we're through with the orthopedic vignettes, and it deserves repetition because the compartment syndrome is clinically a potential source of severe disability if it is not recognized, and it makes a very good examination question. Any physician who might be involved in the care of a patient who is at risk of developing the compartment syndrome has to be able to recognize it. Well, let me repeat again. I say repeat because we touched upon this on the trauma vignettes, that the two most common locations for the compartment syndrome are the forearm and the lower leg. And then a number of things that could lead to swelling of the muscles can produce it, and in this case it is a fracture and the trauma and the alignment and so on. So we shouldn't be surprised that subsequent to the immobilization of a fracture of the legs bones, that the patient might develop the compartment syndrome. And let me add now, the persistent pain is classical, the feeling of tightness in the muscles is classical, but the earliest and most reliable physical finding is that excruciating pain with a passive extension of the toes. And so the answer here is clear. This patient needs a fasciotomy, an emergency fasciotomy. Not tomorrow, but a fasciotomy now. Let me add, I don't think they'll ask you for the details of how to do a fasciotomy. But in case they do, when we do a fasciotomy, we make sure we open all of the fascial compartments of that part of the anatomy. And in the leg, there are 4 fascial compartments. All 4 need to be open. And we don't need 4 incisions to do this. It's done through 2 incisions because each of the incisions is placed at the point where 2 compartments join one another. So there are 2 skin incisions made from which then 4 fascial incisions can be made. All right, let's move on now, vignette 42. An out-of-shape, recently divorced 42-year-old man is trying to impress a young woman by challenging her to a game of tennis. What a pathetic sight, huh? In the middle of the game, a loud pop is heard like a gunshot, and the man falls to the ground clutching his ankle. He limps off the courts with pain and swelling in the back of the lower leg, but is still able to plant or flex his foot. When he seeks medical help the next day, palpation of his Achilles tendon reveals an obvious defect right beneath the skin. This is a classical presentation for the rupture of the Achilles tendon. It tends to happen to people who are out of shape, but put a lot of strain on the tendon. And tennis is one of the better ways to strain that tendon. You're running back and forth from one end of the court to the other, planting the foot, suddenly changing direction. It really puts a lot of strain. And this is how it happens. There is that loud pop, that noise, the patient falls to the ground. Interestingly enough, at the beginning, the patient can still move that foot because the Achilles tendon is not the only anatomical feature that produces that motion. But eventually the patient tires out easily, the pain persists. By the next morning the patient realizes this is not normal. And then physical exam is very easy. It just shows the defect. These can be dealt with casting in an equinus position. Casting has the patient on tiptoes like a ballet dancer, so that that tendon is not stretched, But if you need faster healing for whatever reason, then a surgical repair leads to faster recovery. So casting with healing that will take several months, or open repair for a faster outcome. Vignette number 43. While running to catch a bus, an old man twists his ankle and falls on his inverted foot. Or I might add, it could be the opposite. While running, the individual twists his ankles and falls on his everted foot. Because in either case, we're bound to break both malleoli. AP, lateral, and Mortiz X-rays show displaced fractures of both malleoli. The mechanism of injury then is classical. If a vignette says somebody fell, but as he fell, the foot was either inverted or everted, that's going to break typically both malleoli. If vignette were to say X-rays show the fractures, but boy, they are just exactly in the position where they should be, then we can do casting and expect healing in a good position. But if it says, like I just read, that they are displaced, those two malleoli are way out of place, then open reduction and internal fixation is going to be needed, so you end up again with a good tight ankle joint, a Mortiz that has been put back together the way it should. All right, we're going to move on now to another subheading, orthopedic emergencies. Some of the things I'm going to go over are things that we've already touched upon again, but because they represent emergencies, they have a very high likelihood of being asked on the exam, and they are worth repetition.